everyone. This is Sohail Khan. Today I'm very excited to be with Dan Carey. Dan Carey is my classmate in Master's in Healthcare Management program at Harvard School of Public Health. He's a cardiologist. He's also Secretary of Health and Human Resources for the state of Virginia.
That's right.
Dan, thanks for being here.
Sohail, thanks so much. I'm honored to be in one of your early interviews and looking forward to spending time with you today.
Thank you. So Dan, the United States, we spend 20% of our GDP on healthcare. It's about $3 to $4 trillion. I think it's going to bankrupt us in a few years. With your experience being a cardiologist and now a policy maker, what are the top three drivers of healthcare cost in this country?
Well, that's a great question. I think in Virginia, I think they're similar across, whether it's the Medicaid population, whether it's the Medicare population or the privately insured. Drug costs are certainly one of the fastest growing costs, something that we in Virginia are very concerned about and thinking, how can we better control that? I think it's not just the brand name drugs, but it's also the generic drugs that are now much more expensive than they used to be. And then there's a host of specialty drugs, whether it's cardiovascular drugs, cancer drugs, or even gene therapy that can be as expensive as literally Zolgensma, I believe, a treatment for a type of muscular dystrophy is $3 to $4 million after treatment per person, but it's very effective as well and can dramatically impact the life of a child suffering from that illness. So I think drug costs. I think utilization. I think the aging of the population, especially the dual eligible population, those that are low income in Medicare, but also eligible in Medicaid. With multiple chronic diseases, so long-term care of these individuals and management of chronic diseases is often a challenge when there's a great deal of socioeconomic and social determinant pressure on their ability to stay in the home and get the support they need. So that those two things, drug costs as well as the aging of the population. And I think the third thing to keep in mind, this is, I think, one of the acceptable reasons for healthcare costs going up, because there are new therapies that are quite effective. Whether it's in heart failure or ischemic heart disease or cancer therapy, and I mentioned the emerging gene therapy. So I think those three things are the big drivers in Virginia.
Right, and definitely a lot of challenges. So there is no magic wand. If we have to do anything, like what are the top 2-3 immediate steps we can take in next 5 years to decrease that healthcare cost?
Well, I think there's no magic wand, but I think as we've talked about, it's the total cost is the utilization rates, followed by the price of the particular service, device, drugs, medical costs, and medicine costs. So on the utilization side, I think through better chronic disease management, we can see lower hospitalization rates, but to some degree that people are living longer, they're going to live longer to need the chronic therapies longer. So I'm not sure, I think we definitely can do better, but I'm not sure we're going to get huge changes there. And if you look at our utilization rates, yes, we do some joints more than other joints, but we're not that dissimilar to other developed countries. On the price side, I think there's a real opportunity with negotiations that we don't do that under Part D with Medicare. Hopefully there'll be some movement at the national level. But at Medicaid at the state level, we have a study that's underway this year that will get a report, I believe, in November or December, ready for the next session of the General Assembly, the 2020 session, to see what are the levers that are most promising. There's a number of rebates, and it's a very complex system by which not only individuals but also states purchase drugs through the state health plan and through for state employees as well as for Medicaid. And getting what are those opportunities to negotiate in a stronger, more aggressive fashion. So we're exploring those. So negotiation on drug costs. Second, we have a Common Core formulary across Medicaid in Virginia, so that sends a signal of the most we're looking at biosimilars, the cheapest price that we can get for biosimilars, and making that easy for doctors who participate in care for Medicaid patients.
Right.
And I think the last thing is looking at low-value care. I think low-value care can also be described as waste. Things that I was taught to do as a cardiologist 30 years ago when I was in training, the extensive preoperative evaluations, we realized for a patient with chronic stable angina, for example, or those with unknown coronary disease, focus on those folks who are symptomatic,
Right.
and work on their blood pressure and their cholesterol level and their obesity status and the like, rather than doing extensive workups that identify things that you probably don't need to know about in order to do elective surgery safely. So and that is just one example. There's prostate PSA tests for men greater than 75. There's drop the pre-op, not just cardiovascular testing, but ECG testing. There's a number of other things that, vitamin D testing, for example, unless someone has specific symptoms suggesting vitamin D, it's only, say, a $100 test, but if it's done, 2 million times in Virginia, that's $200 million that really isn't effective. Again, these are the choosing wisely, but operationalizing the choosing wisely. So those three areas: negotiating on drug prices, better management, working with the MCOs and Medicaid to reduce the need for hospitalization, and then 3, focusing in a targeted way with the provider side as well as the employers that pay most of the private health insurance premiums on keying in on reducing low-value care.
Great points. So Dan, as a Secretary of Health and Human Resources, you led one of the biggest expansion of Medicaid in the state of Virginia. What were the learning points? What were the factors that contributed towards its success?
Well, thank you. We have been in Virginia, a team effort, both the General Assembly and the executive branch working together with the governor initiative to expand Medicaid. First state to expand Medicaid after the Trump administration came into office. So it was a compromise. We the Northern administration, Democratic administration, did not want work requirements, but that was the deal. And we expanded Medicaid even as we applied for 1115 waiver for work requirements. So that's working its way through the courts. We are still working with CMS about how to structure work requirements in a way, work engagement, job training, that doesn't push people off of coverage. So